opioid drugs and creating, which is a public health disaster in the United States. So I'd like to close the comments. We can maybe show the short film, and I know I encourage you, even if your English is not so great, my Arabic is non-existent. So please ask a question. We have two translators up here. It would honor me to hear your questions, your concerns, and your thoughts. So, sir, if you could please, let's try that. I brought a couple of them over. I'm not sure which one this is.
Opioids include the opiates, which are the natural alkaloid. Opioids are substances. The impact of opioids on your brain and body. Opioids are substances that produce morphine-like effects. They are used primarily for pain relief, although there are multiple uses for these medications. Opioids include the opiates, which are the natural alkaloids derived from the opium poppy. This class of drugs also includes synthetic drugs, antagonists, and endogenous peptides such as endorphins. When we take opioid medications, they enter the brain and bind to opioid receptors on cells located in many areas, especially those receptors involved in feelings of pain and pleasure and in controlling breathing and hormone release. The chemicals in the opiates attach to specialized proteins on the surface of the neurons. There are three types of opioid receptors: mu, delta, and kappa. It is the mu receptors that are responsible for the pleasurable and analgesic effects of opiates. Opioid receptors are located in the brain, brainstem, spinal cord, intestines, and other organs. When endorphins, our body's naturally made opioids, are released, or when opioid drugs are taken, they bind to opioid receptors in the brain and body to regulate functions including pain, pleasure, breathing, and digestion. Click on the body part to learn about the effects of opioids on that system.
So at this point you could stop and then click on each one at your own pace. We just want to do this as a demonstration. Should keep moving. We'll start right. So this is just an example. Hopefully we can get it to go through, but this is online learning that hopefully is more engaging. I mean, a little music that makes it a little bit more encouraging, and these are very...
The linkage of these chemicals with the receptors triggers the same biochemical brain processes that reward people with feelings of pleasure when they engage in activities that promote basic life functions, such as eating and sex. The activation of the reward center is the primary reason opioids can lead to addiction. One of the brain circuits that is activated by opioids is the mesolimbic midbrain reward system. This system generates signals in a part of the brain called the ventral tegmental area, VTA, that result in the release of the chemical dopamine, DA, in another part of the brain, the nucleus accumbens, NAC. This release of DA into the NAC causes feelings of pleasure. Feedback from the prefrontal cortex, PFC, to the VTA normally helps us overcome drives to obtain pleasure through actions that may be unsafe or unwise, but this feedback appears to be compromised in individuals who become addicted to drugs. Dependence is the need to keep taking a drug to avoid the effects of withdrawal. The effects of withdrawal impact most body systems, just as most systems are affected by opioids. Click on the body part to learn about the effects of dependence on that system.
You could stop and click on any body part you'd like here.
Addiction is the intensive craving leading to compulsive use. Addiction results from changes in the reward system of the brain. Treatment for addiction requires a comprehensive, multifaceted approach that includes behavioral therapy, family counseling, support services, and medication. Pharmacological therapy used in medication-assisted treatment, MAT, is a critical part of care for opioid use disorder. These medications reduce the symptoms of withdrawal and may reverse some of the brain changes associated with addiction, greatly enhancing the effectiveness of behavioral therapies.
So I actually brought a few other examples, but I think I'd rather, in the sake of time, I have about 10 more minutes. So we have an entire curriculum that is this type of, high-end graphics, and the learner can stop at any point and review it, go over the individual body signs. So there is actually, this is one tiny piece of a much larger curriculum in gaining knowledge and skills and expertise in the role of opioids. And some of them, again, I don't, you can see I brought many of them here, but I'd much rather hear from you and hear from our respected colleagues here. So let me just stop. We have, according to my watch, exactly 10 minutes. I wish we had more, but I don't want to take away from our other presenters. Please, questions, comments, ideas, and please, you cannot offend me. The only offense I take is not asking any questions. Thank you all very much. I hope we get a chance to work together on education and training with your prestigious Kasr University and my University of Western Youth, inshallah.
They can ask the question now.
يا أسئلة حضراتكم تحبوا تسألوها حتى لو بالعربي واحنا نترجم. اتفضل يا دكتور.
I'm not sure I quite grasp this. Is this for undergraduates? This is for undergraduate training?
We have the training everywhere from, so there's different versions. We have it for nurses, social workers, undergraduates, residents, junior faculty. We even have a version of it for senior faculty. So each level enhances the quality. So, but we have many different versions. It's just like, you might take pharmacology as a medical student might be different than an advanced pharmacology course if you're already associate or a full professor. So we've developed many different levels. For the master's program, it's a little higher level. But the advantage
of having many is that people at many different levels can engage. And it's meant to be enjoyable, to have it be fun. Now we do have assessments that measure not only, we're not interested in how many questions did you get correct, which we normally have in medical school, but are you competent? Do you have the knowledge and the skills and the behaviors to take care of addicts? So we have, the assessment is something that is, it's computer adaptive learning, but it's a way to make sure that people have the competence without feeling nervous that I passed the test. So this is advanced learning styles that we do a lot of. I have over 20 people in my university that only work on the computer version of measuring competence. Thank you.
I think we have with Professor Maha, the head of the addiction unit, a program to the house officers, to the 1,500 graduating house officers every year. So can we talk to design a program for the physicians all over the country? Because some of our obstacles with our patients in psychiatry or drug addiction are the pharmacists and the physicians. Don't take this and don't take that, it will make an addiction. Or did you apply for physicians, non-psychiatrists?
Yes, yes. At my university we have 9 different health colleges. So your question is very important, because one of the things that we see is that individuals who want to treat sometimes make things worse. So what we want to do is train everyone. And we have this developed. And the advantage of being online is we could train 1 million people. All they need is a computer. So the reason we've developed this, I got a very large grant from the United States government to help us develop this. So it's always easier when you get let's see, it would be a million, it would be a little over 17 million Egyptian pounds. But it's meant for physicians, for internists, family physicians, surgeons, residents. It is not just for psychiatrists. So we have versions that are appropriate for people at different stages of training and even in different disciplines. Nursing students, dental students, practicing nurses, practicing dentists. Dentists tend to overprescribe a lot of pain medicines. I don't know in Egypt, but in the US, someone gets a tooth extraction or wisdom teeth and they give them too many opioids. And we've actually been able to measure this in the United States. I'd very much like to measure it here in Cairo and in Egypt, but we found by training dentists how to use pain medications more appropriately, we've been able to see somewhat of a decrease. So the plan is to work with your university and train people, as many as possible, because it's very inexpensive. No one has to travel.
There is over-prescription by the venereal specialist and the post-operative surgeons,
Yes.
whatever the...
Yes, so we have a very specific, at my university we have a college of pharmacy for PhDs in pharmacology. So to educate people how to use pain medicines in a way to limit the potential for addiction, or to identify the individual who might be at risk so that you would maybe not use opioids, use other forms of analgesic medications.
Professor Abdurrahman.
Regarding addictive substances and psychosis,
Yeah.
in my clinical setting, I observed that the most addictive substances less psychotic, يعني opioid, nicotine, less psychotic than cannabinoids and amphetamine, cocaine. What is behind this observation?
Yes, and in fact that's an observation that many have made. So your observations are consistent with what we've seen across the world. It's been very interesting. In the United States, there are a number of states where marijuana is now legal. Like California, where I live, marijuana is legal. What we've seen in our adolescents is an increase. People who use marijuana having their first psychotic break. So there's something about the biology of psychosis that seems to be related, that people with, as you say, drugs, marijuana is quite, amphetamines, quite common. That there's something about those drugs that seem to lower the threshold for a psychotic episode. But we also know from the work on sensitization and kindling that once you have that first psychotic episode, you have many more. And that we do know a little bit about the biology. Why it is that the opioids per se we don't see an increase so much in psychotic behavior, but what we see is a very difficult time stopping the use. So the repetitive behaviors, we think that has to do with the direct impact of the opioids on the reward pathway. So actually, if you're interested in this, I published over the last year about 18 papers looking at the biology of reward systems called the Reward Deficiency Syndrome, RDS. If you Google, you'll see I've published many papers on that just the last year or two. It seems like the opioids do not trigger as much psychotic illness, but they very difficult in hijacking that reward pathway, the mesolimbic dopamine. Where in other drugs, we use, it seems, activation of tuberoinfundibular dopamine, which is more associated with psychotic illness.
Welcome, dear Professor.
Thank you.
This is an online training. Have you done any comparative assessment or assessment between the level of the trainee in official classroom training and the online training? You know, sitting with an addict requires not only knowledge, it requires tolerance, acceptance, skills, many things. The dropout can be because of the therapist's tolerance, because of the level of intervention, how far is it deep, how far is it superficial. So how can you assess that the online training would give professional therapists, professional nurses, you know what I mean, that can make successful therapy? Is there any assessment for the level of the trainee after the online training?
Yes, and your point is a very important one, because this is not meant to make an expert, but to give someone the foundation to then go and get the clinical experience. We all know in medical school, when we learn to do psychotherapy, we might learn the techniques. What makes us a good psychotherapist is seeing patients, is the clinical experience. So this is not meant to be done in lieu of clinical experience, but it's to give the experience to that be more effective, because we all know as clinicians, we learn how to do it by taking care of patients, by seeing the patients don't read the books. So we learn one way, but then we gain clinical experience by being in the clinic, sitting with the family, sitting with the patients. This is meant to build that foundation, to then build clinical experience, because one without the other is not as effective. So your point is a very important one. We don't want people to think, well, I've done this training and now I'm an expert. No, you have knowledge that will allow you to become a better clinician. Now, we have looked at online learning versus sitting in a classroom like this. And it turns out that if you do high-level online learning that we've tried to do here engaging, the younger generation prefer it and learn better because it's consistent with what they've grown up with. Older generations, gray hairs, like me, we are used to learning in a more, what they call passive learning. You sit there, you listen, you nod your head, you hopefully don't fall asleep, right? And then the exam comes and you hope you get 75% of the questions correct. What we're finding is in the younger generation, that style of learning is not as effective. So what we found is engaging, because the student, as you see here, they stop and they get feedback. They can literally ask. So it's not as much passive learning. It seems to be in many areas. We've actually done studies in Singapore and some other areas. So it seems to be a very effective strategy, but it's one piece of a larger puzzle. So your question is very good. So we tell people, now what you need to do is apply those knowledge and skills that you've learned, and then sit with an experienced supervisor and see patients and their families. So again, this is one piece. We think it's an important piece, but one piece of a bigger puzzle. The best clinicians are not the top students coming from medical school. They're the students who went on and have seen thousands of patients in their careers and understand the nuance of pathology.
As we know that opioid acts on a pre-neural system, acts on nucleus ventral tegmental area that releases dopamine, nucleus accumbens, as you told us, that accompanied by a feeling of pleasure. Meanwhile, other brain areas associates this feeling of pleasure with external environment, but may excuse later on for craving. My question is, if there is any difference for the patient who is receiving opioid analgesics for pain and another one who receives opioid without pain, if there is any difference in the pathogenesis, in the neurobiological changes in the brain?
Yes, it's a very important question. So those who maybe couldn't hear in the past, is there a difference in the addiction that maybe is related to pain as opposed to someone who just wanted to get high? And it turns out that there is. Interestingly, the effects can be measured by the brain white matter, something called diffusion